First of all, let me start thanking Fernandez Hospital for accepting me as part of the family and repeating the invitation to come and join you in this wonderful annual scientific extravaganza. When I was asked that this is what I am supposed to talk about, and to put the heading for a topic, the topic was given as it is printed in your program, the key players. I had a few ideas in my mind, so I thought I will deal with it fairly all right. When I sat down to frame the talk, then I realized how presumptuous it was on my part to think that we can have an answer to a problem which has eluded so many people for so many years. So what you are going to hear are my thoughts about it, very imperfect and incomplete, but let's take it as a starting point for discussion. I have been asked to dwell on this aspect, maternal mortality and Indian perspective. You just heard from Professor Catherine what it is in the UK, but as all of you may be aware, it's a very current topic in Indian media. And the reason for that is because of the discussion on Millennium Development Goal, which we are supposed to accomplish by 2015. And the question is, will India achieve or meet the goal? And the goal is to have an MMR of 109 by 2015. But we all know we are nowhere near. The maternal mortality of India is a blotch on our conscience, on our prestige. When we hear that 25% of maternal deaths globally is taking place in India, certainly it is not something we can be proud of. But we have to remember this is the same country which is hosting the Commonwealth Games currently on, spending how many crores, I don't know. We are planning to bid for Olympics, and how many more crores it will need, I don't know. We are planning to send man, or probably a woman, to the moon in the near future. But there are many reasons for this plight that India is having. The vastness and the diversity of India is probably the most important reason for that. If you look at India and compare it with UK, where Dr. Kadir is coming from, you can see that India is about 25, 26 times bigger in size, and population-wise much more, isn't it? I think yesterday some speaker was saying they don't know the population of India. Now it is standing at about 104 crores. And if Dr. Catherine, if you are not aware what a crore is, you know, that is 1,200 million. So, I mean, it is much amazing, the number of people we are dealing with. But all along, the spending on health had been just peanuts. We have been spending 0.9% of our GDP, that is gross domestic product, on health. And that had been on since independence. And after the present government took over, the previous term, they said that they are going to raise it to 2 to 3%, but it didn't really materialize. And we have to see that all along, the developing world had been in this range, but the developed world had been spending about 6 to 9% of their gross products on health. And you can see the disparity economically that was going on. And this is reflected in the field. If you look at the vastness of the country, then another factor we have to realize is there is no homogeneity in the country. There is a rural-urban divide, and we know that 80% of India lives in the rural areas. And if you look at the maternal mortality of the rural, compared with the urban, it is 3 times. If you look at the care they get in labor, the skilled birth attendant in the rural area is only about 34%. That is just an estimate. In many parts of our country, it is much less than that. Whereas in the urban areas, it may be higher at about 73%. Poverty is another really tragic fact. As of 2004 and 5, 27.8% of the Indian population were living at below $1 per day consumption. 41% of our women and 18% of our men have never been to school. That is National Family Health Survey 3. Age of marriage. Early marriage is still so prevalent that 16% of girls, that is 15 to 19 years, are already pregnant. We are not talking about the unwed pregnancies. We are talking about the real married pregnancies. And if you look at the urban-rural divide, the pregnancy in the rural girls is twice as much as in the urban areas. To complicate matters further, we know that health is a state portfolio. Even though central government puts in money in national programs, primarily curative health care is a state project. And we know the diversity of the states in India. You look at the different states, size-wise, population-wise, and the living standard-wise. That is another factor that has contributed to this. And healthcare itself, unlike the UK, where you heard about the National Health Service provides free health to every one of its citizens, and many of the European countries do the same, whereas here, there is the private and the government facilities exist, but the poor depend on government facility only. And government facility, there is nobody to ask if there is shortage of doctors, shortage of equipments, shortage of funds in general. How do they spend on it? From their personal funds. There is no insurance coverage. And when you look at the health centers provided by the government, we know that there is not enough centers available. And even if they have, they don't have doctors or nurses there. And of course, one of the reasons quoted is that not that we don't train people, but the trainees are going abroad. And worse than anything else is the corruption that is at the root of many of our problems. In the utilization of funds, we earmark less for health, and whatever is earmarked, a lot of that is not really reaching the target it should. And even the poor have to bribe for free services, so-called. You know that the government has now the Janani Suraksha Yojana, where those who have institutional delivery gets an allowance, maybe about 1,500 rupees. Tamil Nadu gets about 7,000 rupees. But to get that, they have to pay a cut to the people who provide it. So that's the way things are. But let me not be all pessimistic. We should realize that it's not all reasons for despair, even in our country. We have come a long way since independence. If you look at what our maternal mortality ratios were, at independence, the board committee estimated that it was 2,000 per 100,000 live births. Mudalia committee has come down 10 years later to 1,300. But sample surveys in 2003 said it is 301, and in 2007, 274. But we all know that sample surveys do not really represent a very, probably a realistic suggestion is that you multiply it by 1.5 to get probably the real figure. So that is where we are at the moment. And bringing it down further is going to be more and more difficult as the figures come down, that we know. But can we wait for our infrastructure to improve to get the maternal deaths averted and avoided? I hope all of you will agree that we cannot. And that is why Evita asked me to just dwell on this aspect. Who are the key players who can make a difference and help in bringing down the maternal mortality in India? And I wish we had just this one solution to the problem, one key to the whole thing. Looking at it, we can realize that it is not just one, but there are many. There has to be many key players, looking at the diversity of the country. But to suggest what we can do, what we really want to have the information is how many mothers die. Do we know that? Unfortunately, we do not. And then, do we really know why they die? And unless we know why they die, how can we suggest solutions to the problem? Only if we know answers to these two problems, then, and only then, can we find out what can be done about it. So as whenever there is a problem, this is what we can do. We have an inquiry commission and ask for the Supreme Court sitting judge for it. Anything bad happening in our country, immediate clamor is get an inquiry commission put up, spend a lot of government money on that, and finally after a few years, commission report will come, nobody will know where it has gone. Is that the answer? Way back in 1952, you saw the graph Catherine put up, where the maternal mortality rate came down. And in early 1950s, when the Confidential Review of Maternal Death started in the UK, they made one important decision. Review of maternal death has to be done by practicing obstetricians and, of course, allied specialists, not by a non-medical person. It is an important decision, and that should hold true for obstetric audit anywhere in the world. And we know that there are different types of audit. The classical clinical audit is there. There's a facility-based audit, a clinical audit limited to the institutions. But there's a confidential review of maternal deaths that had been there in the UK, now adopted by many other countries in the world. When we don't have enough maternal deaths, that's a problem in the Western countries. They don't have enough maternal deaths to audit, so now they audit near misses. And if you don't have institutional deliveries, you go to the community and do the verbal autopsy. Confidential review of maternal death is the best. Because of the basic principle involved, there is confidentiality. And so we know that truth will come out. There are no names mentioned, and there's no blames. And there is no punishment or even bad reputation out of that. And only if these are guaranteed, we know that the truth will come out. And that is why confidential review of maternal death is the best. In our state of Kerala, since 2004, we had been doing that. We started with the help of WHO. Our government supports it, of course not to the extent we would like, but at least it is not against it. All hospitals, private as well as public, take part in it. It is done as a voluntary work by practicing obstetricians, no payment for that. And all our obstetrician colleagues join us, and non-obstetrician colleagues also join when it is required. For those of you who are interested, if you want to know how it is done, we collect the data, anonymized case sheets, sent to different assessors, but 3 times or 4 times in a year we sit together, the assessors and the expert committee members, and go over the case sheets once again and find out what could be the best reason for the death of that patient. I do agree with you, Professor Catherine, autopsy would have been the better way, but at the moment it is not that prevalent in our community. If anybody is interested to see how we do it, our next meeting is on 7th November at Trichur in Kerala. You are quite welcome. Now, the principles of confidential review doesn't have to be employed in a state level. My feeling is that the important aspect about is confidentiality. People who give out the information should be clear that they will not be blackmailed because of that. They will not be taken to the court because of that. Once that confidentiality is there, then only the truth will come out. And even hospitals in a city can get together. Part of a state can get together. A city can get together and do the confidential review of maternal deaths. What is important is that there should be no fear of shame or punishment if they reveal the truth. And I think senior obstetricians have to lead the way. They have to shed their ego and show the way for the juniors. We came out with our publication in the first 2 years' findings in the form of a book, and I have no shame in accepting that this is almost an imitation of what is happening in the UK. It's in the same pattern we do it. This is for the first 2 years, and we do have the same lineage as you have there. And those who are interested, you can have this book at a subsidized rate if you write to me. Now, what did we find? In 2004 and 5, we had about 5 lakhs plus deliveries, but we had about 154 and 153 deaths brought to our attention, which will work out to be about 28 per 100,000 live births for our state. We know that this is an underestimate because all deaths were not reported to us. But this is the best that we could get for the state. Even if you double it, the confidence review figures are doubled, still the maternal deaths in the state of Kerala will be in the range of about 50, that's all. Now if you look at the national figure, you can see that the hemorrhage, this is a Canadian combined work with the Indian government, and they came out that 38% of maternal death in our country is due to hemorrhage. Agreed. But if you look at the other causes, the sepsis, hypertension, much lower. This is not true for the whole of India. If you want to know what is really happening in your own state, you have to study your own state. And this is what we found in our state. And if you look at the figures, you can see that hemorrhage is top in the list even in Kerala. But closely behind that is hypertensive disorders. And you can see at the top, amniotic fluid embolism was the third cause. I was surprised because when we were students, amniotic fluid embolism was so rare. Why did it jump up to that? We'll come to that probably in a minute. Sepsis, not an insignificant cause, but not due to septic abortion in Kerala. So to know what is happening in our own state, we have to analyze our own figures. And compare it with the UK, the figures you already saw. They have heart disease as their major problem, but thromboembolism is right at the top. For them, hemorrhage is no more the leading problem. Hypertension is no more the leading problem. But venous thromboembolism is the problem. Psychiatric problem is a big issue. So it depends on where you are working, what your population criteria are, and then only we can do it. For us, as a result of this audit, we found that the leading cause is PPH, which is a largely preventable condition. So we decided we have to address it more aggressively. We decided that we can look at it in the same framework of the 3 delay model of the delay in seeking help, the delay in reaching help, and the delay in getting help. It's applicable even in our state. But the basic approach to PPH has to be streamlined. This is the fundamental thing that we are trying to teach our peripheral doctors. IV access and volume replacement when you refer the patient. Otherwise you get a dead patient when they reach the higher center. Primary treatment with drugs. Active management of third stage. Tamponade when you refer the patient. And if it's small bleeders, hemostatic stitches. And we have to teach our juniors how to do obstetric hysterectomy. We found that condom tamponade is an effective method in tackling atonic PPH. Very cheap. In fact, the main problem with that is it is so cheap, which can be improvised, and we teach our people that. We have to teach them that a cervical inspection set has to be readily available in every labor room. But when a delivery occurs and bleeding occurs, you want to see a cervix, you have to run around for a speculum. Not that. You should have a ready-made set for that. So the minimal instruments required have to be readily available. And we said about amniotic fluid embolism. We found that probably it is an escape diagnosis, because in Kerala, as you may know, the public will be so agitated and attack the hospitals and doctors if they feel that negligence has occurred. So if you say amniotic fluid embolism, safer. But not only that. When we analyzed the cases, we found that surreptitiously certain practices had got into our obstetric care. People started to use misoprostol very freely. I also recommend it. But along with that, they started to use vasodilators even when the cervix is 8 centimeters dilated. So you are using a vasodilator in a condition where already the cervix is edematous, easy to tear, and I am not surprised that amniotic fluid embolism went up. Realizing this, yet last 2 years we have been aggressively approaching this, telling our colleagues, and it has made a big difference. The amniotic fluid embolism incidence has come down. Hypertensive disorders, the second cause in our state, we could address it because Maxwell was not being used. Now it is being provided, and hopefully the cause as a hypertensive disorder as a cause will come down. But still, aggressive approach to bring down the blood pressure is not yet widely practiced. So cerebrovascular accident is equal cause of maternal death in hypertensive disorders as is eclampsia. So we have to address that. Venous thromboembolism is going up in our state. So we have to think about thromboprophylaxis even in our patients. We have to make sure that labor rooms have an emergency kit available. It should be a standard, not that when an emergency occurs, they run around. We analyzed regionally and locally and found that marginalized segments of the society are still suffering. In one district where 1/5 of the population only are tribals, 16 out of 20 maternal deaths occurred in the tribals. So even though government is doing so much for them, it really doesn't reach the people. Transportation is still a nightmare. We don't have a regular ambulance services. We don't have the real needy people transported at the right time, and because of that, death occurs. So for the referral system, we have to streamline that. And we thought that we should recruit even private hospitals. We should recruit the private ambulance services to make sure that people are taken to the right place at the right time. So coming back, who can be the key players? As I said earlier, this is just out of my head. The patient and the family certainly comes first. The medical team, including the obstetrician or the physician as the doctors and the nurse midwife. The hospitals, both government and the private. The administration, not just the bureaucrat, but the politician also, and the society at large. These are the key players I will put down. To each one, I will give a key. Patients, family, and their awareness, their knowledge of their rights is probably the most important. We know that only the baby who cries gets the milk. Similarly, unless the people are aware of their rights and demands it, they won't get it. There is a lot of work needed in that direction. Coming to the doctors, we know that the training of the medical doctors, including obstetricians, need reorientation. Are we prepared to tackle emergencies as we should be? And I think those in the periphery and the government service should be empowered to deal with even finances. Coming to the nurses and the midwives, unfortunately in India, status of midwife went down. If you go to UK and work, they are the bosses there. Even the consultants cannot go into the labor room without their permission. But here, we know what credibility they have. What happened was, the midwifery training for the general nursing training was downgraded. Even the A&M training, the duration of exposure was reduced. So no wonder midwife doesn't have the respect it deserves. But in India, at least there's a congenial relationship between the obstetrician and the midwife. I think we have to maintain that. But any reorientation program we think about should involve the nurses and the nursing assistants, then only it will have its result. Hospitals, whether under the private sector or the government, I think there's a paradigm shift required in our outlook towards private hospitals. When they provide patient care, it has to be seen as a service to the society, not as a money-making business. And the hospitals, private or government, should be mandated to cooperate in the audit process, and the responsibility has to be not on the obstetrician, but on the hospital administration. We should encourage public-private partnership. Follow the example, what happened in Gujarat, the Chiranjeevi project, where for the services provided, the government pays the doctors directly, without red tapeism, paid in advance, so that there is no hesitance for the private hospital to access that service. You look at the UK, everybody says about the National Health Service in UK. What's happening there? The GP practice, which is the main core of the service care there, the GPs set up the practice, government pays them, almost like the private setup here. The midwives there visit the patients in their homes. They go in their own vehicle. Maybe the government pays them the allowance for a car allowance. But here what we would have done, we would then buy a hospital car or ambulance, employ a driver, but there will be no money to buy the diesel for that. So we have to look at these things in a practical sense. Bureaucrats, I think the best thing that this country has, if they are allowed to work, well-meaning, honest and bold bureaucrats, without political interference, then they will do wonders. But I feel that they should use managerial skills currently available and use the developments in technology and communications. And coming to the politicians, they are the policy makers. They provide money. They decide how much of the income of the government has to be spent on health. And so they have to be converted. They cannot be sidelined because they are the ones to decide on money, and money is the key. If there is enough money paid, any service you can get. Look at the example of Saudi Arabia. A few years ago, I looked up at their maternal mortality ratio, 25. Is it because all their women are educated? No. The government there bought the services from people all over the world and provided it free to their community. And if you have money, if you pay well, I think even Catherine Nelson Piercy will come and work here in India. Ma'am? No. Okay. And even Evita will set up hospitals in the rural setting. I think society should realize the value of the service the woman is providing when she consents to get pregnant and have a baby. Without that, the human race would have been extinct. But we should make sure that she's not made to lose her life in that process. But how can we carry this message to the people, to the society at large? Only the media and the icons take it up, it will happen. We have to have people. As you and I say this, I don't know, maybe you will listen, but the society doesn't. I think we have to have people like this, or you add to this list Sonia Gandhi or Manmohan Singh or some others also, but we need them to come out and realize what is really required. What is required is society has to decide how much is the price tag on a woman's life. I'm always reminded of this statement by Mohammed Fathallah, who was the president of FIGO 2 terms before. And he said, these young women are dying, not because the technology to save their lives is not existing, but because the very society is yet to decide whether their lives are worth saving. But who can be the prime mover to bring about the change? I mentioned a few key players, and I feel that out of them is the obstetrician who can play a pivotal role. Because out of all the professionals, it is we, the obstetrician, who will be at her bedside when she passes away, who will see that orphan baby and meet the relatives. So if we are not moved, I don't think anybody else will be moved. And we have to take it up as our responsibility. And if we make a sincere effort to find the real reasons why these women die, and try to do whatever is possible to avert these maternal deaths and disability, then only it will make a change. I think we have to think beyond the medical reasons, whether it was cardiac arrest or hemorrhage or thing, the social factors as well. That is possible when we have the confidential review of maternal deaths. And only through confidential review of maternal deaths, we can know that real truth and then make a difference. So I appeal to you, in whatever setting you are, to have that mindset, to have review like that. I would just end with this example. This is a patient. This is not a story. This is what really happened. This patient had thyroid surgery. She was taken to the ward, and after a while, she started to have difficulty in breathing. So the relatives went and called the nurse, and the nurse came round, and by then somebody thought she's having breathing difficulty, go for the oxygen cylinder. Found an oxygen cylinder somewhere, brought it then. But then they looked for the spanner to open it. They didn't find it. So there was a lot of commotion by the time the patient choked to death. Of course, an inquiry commission was put up and the ward attender was suspended. What obviously had happened, as you can imagine, she had hemorrhage there, and the spanner, even if it was available, the oxygen cylinder was empty. Fortunately, it was not identified. Whose guilt is it? Whose mistake is it? If you have an immediate inquiry, because they want somebody to be pinpoint, that is what will happen if you just go on the face of what really happened, rather than go into the deep depth of it. My plea is that let us not be carried away by superficial aspects. Let's go to the depth of it, and then only real reasons will be identified, and then only we can make a difference. Thank you very much for your attention.